Welcome everybody to this webinar on World Arthritis Day, October 12, 2023. I am Loreto Carmona. I'm a rheumatologist and epidemiologist from Valencia, Spain, and I am also the chair of EULAR advocacy. And I'm here with my dearest colleague, Susie Macri, who's a patient research partner from Cyprus, and she was previously president of Agora, which is a platform of organization for people with rheumatic conditions from Southern Europe, and also of ENFA, the European Network of Fibromyalgia Associations, and currently she holds the position of past chair of EULAR PARE. All yours for the introduction to this webinar, Susie.
Thank you, Loreto, for this nice introduction. I wish to welcome you as well at this webinar, a topic of which is living with an RMD at all stages of life. Very interesting topic, and we will hear more about it from our speakers, and we will also have a very interesting personal experience, which will show us the way that the person is dealing with all the challenges that are faced with an RMD. So without further ado, I will introduce our first speaker for today, who is Dr. Margriet Kloppenberg, who is a rheumatologist and clinical epidemiologist working as full professor of rheumatology in the Leiden University Medical Center in the Netherlands. She's also active as educator in training of young rheumatologists, and she serves as president of the Dutch Society of Rheumatology and as a chair-elect for the advocacy committee of EULAR. Margriet, the floor is yours.
Thank you, Susie, for the nice introduction. And thank to all the attendees that are here today to be present at this webinar that we organize for World Arthritis Day. And I hope with this presentation that I will convince you all that rheumatic musculoskeletal diseases are a serious threat and that they have a high impact on all the individuals that suffer from it. And in my presentation, I will especially focus on the elderly. And then I ask for the next slide. And in the next slide, I think I make more clear why I will focus on the elderly. It's not that rheumatic and musculoskeletal disease cannot be seen also on younger ages, and that you will hear in the next presentations. But in the elderly, it is so burdensome because it is the most important cause of physical disability. And to illustrate that, I brought a graph. This is from a big study from the Global Burden of Disease study, which gives a worldwide impression of disability, which is here depicted as years lived with disability, which you see on the y-axis. And they did that for all different age groups. And they also did it for 22 different disease causes. And the purple one, that's what I circled with a red circle, that is what it's depicted for the disability due to musculoskeletal diseases. And you can see that is really a great area. And what you can also see is that it is especially in elderly, but already in younger age groups, especially also in age groups of working age. Then I want to go to the next slide. Oh yeah, before we do that, one extra topic, sorry. It's not only the physical disability, but that's maybe not what primarily people think of, but this kind of diseases also have an increased risk for mortality. And then we go to the next slide. When you think about rheumatic and musculoskeletal diseases in the elderly, then we have, I think, two groups. On the one hand, we have people with these diseases that already developed at younger age. But most of these diseases are chronic and they are not curable. So when people get damage from it, that accumulates over time. So people really even more suffer from that when they are elder. And I think here you see the painter Renoir when he is at older age. I'm always impressed. He had rheumatoid arthritis, and you can very well see how that inflicts with a lot of destruction of his hands, but it also illustrates what is the will of people with rheumatic musculoskeletal disease to overcome their impairments and do that kind of things they really like. On the other hand, you have diseases that are specifically for patients in older age groups. For instance, polymyalgia rheumatica, that is a disease that affects the muscles, but sometimes it also can lead to a vessel inflammation in the temporal region. That's what you see depicted here on a very old painting from Jan van Eyck from the 17th century. But this disease we even also see now, and people then are at risk to become blind, even today. But when we think about disease that is especially present in older age, then it is osteoarthritis. And then I want to go to the next slide, because I think osteoarthritis many of you have heard of. Next slide. No, next, yeah. And that is a disease you can see in all the joints, but we see it especially in the knees, the hips, and the hands. It's characterized by bony enlargements at the joints with sometimes deformities, and I think it's here very clearly illustrated at hands with hand osteoarthritis. But when you have the possibility to have a look inside the joint, you would see that there is a loss of cartilage and there is also some mild inflammation going on. And people then experience pain and functional disability. Next slide. And then to get more impression of what's going on and how that affects the lives of people with osteoarthritis, I show you here some results of a survey that was held in the Netherlands, which was initiated by the Dutch Arthritis Society. And this survey was done under 1,300 participants. And here it became clear that 26% of those with osteoarthritis cannot live the life as they wanted. And I think this is impressive. And when you read all the different responses, you see the frustration, the pain, and the disability of all these patients. Next slide, please. The question is, of course, always, especially when you think, what can we do about it, is what is the cause of osteoarthritis? And it has long been the thought that it is a kind of wear and tear. It's a kind of inevitably aging process. But I think we now know that it is not true. Please, yes. And I think we now consider it really as a disease. And when you press the button, Alexandra, then this is how it's now thought of. It's thought of that during life you get mechanical injuries of your joints. That can be very small ones or bigger ones, but they inflict injury on the joint, and then your joint wants to repair that. And these repair processes are maladaptive. And then you get the abnormalities that you see in an osteoarthritic joint. Then you can also understand why this increases with age, because during the aging, there is an accumulation of injuries. But what you also see is that the repair processes are more maladaptive when you are older. Now, on the right, you see a graph of the global prevalence, so worldwide in 2020, of osteoarthritis for females and males separately for the different age groups. And you see that that goes up around 45 years of age. And really, there is a steep increase. And when you look above, in the elderly group, above 60, 65, then you see that more than 30% of the patients of the persons, individuals worldwide have osteoarthritis. I really think that is a lot. When you think about the aging of the population that we see now, you can understand that it has great impact on society. Then we go to the next slide. The other important risk factor for osteoarthritis is obesity and overweight. And when you press again the button, you see that I think that's what most of us also think of, is that it is the overloading that can lead to injuries on the joints. But that's not the whole story. It's also the fat tissues we now know that release mediators that can also be harmful for the joints. So you can imagine that when we now see that there is an increase in obesity in the population, also that has a great impact of prevalence of this disease in elderly in our society. Go to the next slide, please. And that's what you see here globally depicted for what we see now and what is expected over the coming years. Because what you see here is an estimation of the prevalence about the number of patients with osteoarthritis in the coming years. And here you see a graph for knee osteoarthritis. And the expectation is that in 2050, 642 million people will have knee osteoarthritis. And when you look for all types of osteoarthritis, so also hands, hips, and at other sites, it is even more than 1 billion. Can we go to the next slide? So then, of course, the question is, what can we do about this? Now, you already see in big in the bottom that there is no cure available. But what we now do is that we advise on living a mobile life, being active, doing exercises, and manage a healthy weight. In some people, medicines or injections for pain relief may be helpful, and in some patients, there is surgery needed. To the next slide. I talked a lot about the impact what you see on the joints in patients with rheumatic musculoskeletal diseases, but I think that's not the whole story. We also have to think about a wider impact of these types of diseases. The first I want to mention is the impact it has on workplace-related health problems. Patients with these diseases often encounter problems at work, lose their jobs, or face an early retirement, which have consequences for participation in society, financial consequences for the individual, but also for society. Another problem is that during life, patients with rheumatic musculoskeletal diseases also often have other diseases as well. That could have to do with the fact that there is an overlap in underlying disease mechanisms, but it is also because we now know that patients with rheumatic musculoskeletal diseases are also more at risk, who have cardiovascular diseases or cancer. And I showed you already a little bit on one of those earlier slides that we now know that people with these diseases also have a higher mortality rate. And the last point I want to mention here, that's also a problem really in the elderly, maybe go one back still, is that people with these diseases have more mental health problems, higher rates of depression and anxiety. You can imagine that has to do with loneliness or not being able to live an independent life or participate fully in society. And all these things decrease quality of life. And then we come to the last slide in which I want to give my conclusions. I think I showed you that rheumatic musculoskeletal diseases are prevalent, especially in the elderly, with great impact on disability. And I think that asks for action to mitigate the burden of disease and improve the quality of life of individuals with these diseases. Furthermore, I showed you that most of these diseases are chronic and not curable. So that also warrants better treatment options and prevention strategies. I thank you for your attention.
Thank you very much, Margaret. I think you made it very clear. To all the people in the webinar right now, please, if you have any questions, remember to write them in the chat, and we will post them to the speakers later on. For now, it is my pleasure to invite our next speaker, Professor Fabrizio De Benedetti, who is a pediatric rheumatologist from Rome, Italy. So he's the Chief of Division of Rheumatology at the Children's Hospital Bambino Gesù. He's passionate about the rare diseases of children, and his motto is, "We care for children and arthritis, with arthritis, without arthritis." And talking about motto, he drives a scooter through the streets of Rome and will always carry his helmet to solve problems, which he does with a smile. All yours, Fabrizio.
Loreto, thank you very much. But Loreto is a friend of mine, so you should take with a grain of salt what she said. The next slide, please. And you should actually skip. So you should actually skip this. Sorry. I'd like to start by simply reminding myself where rheumatology comes from. Rheuma comes from Greek, and it describes a mechanism of disease that has to do with humors on fluids capable of determining disease, and that's inflammation, and that's synovial fluid in joints. That's what we refer to, and therefore rheumatology is linked to musculoskeletal symptoms, as was rightly pointed out by the previous speaker. Now, next slide, please. Inflammation is usually good. It's part of our defense mechanism against tissue damage, and we have heard about tissue trauma and interaction with inflammation in degrading cartilage in the elderly. This does not happen in children, obviously. Inflammation is great for defense against microbes. However, there is pathological inflammation that is driven by reaction to self molecules, our own molecule, that's autoimmunity. And sometimes it's induced in the absence of triggers, pathological induced in absence of triggers, and that's autoinflammation. And we know that we fracture a bone. We get heat, redness, swelling, pain, and loss of function, which are considered the 5 pillars of inflammation, are actually these symptoms, the main symptoms of the musculoskeletal disease. Next, please. Now, rheumatoid in children at any age, yes, this may happen. And although we always think about rheumatism of something of the elderly, it's actually present in children. I'll make 2 examples. There are rare genetic monogenic diseases that have neonatal onset. Next slide, please. Alexandra, and that's, for example, is DIRA, which is the genetic deficiency of one of our natural antagonists of cytokines, and these newborns become severely sick with skin and bones inflammation, and eventually severe disability and death if untreated. The next slide, please. Now, there are also polygenic, let's say, standard chronic arthritis that may actually have onset very early in age. This is typical for antinuclear antibody positive oligoarticular JIA. I'll come back to that in a minute. And usually they have chronic arthritis, not rarely before they even start to walk, before 1 year of age, usually knees, ankles, and this has a severe impact on neurocognitive development as well as, for example, growth with leg length, leg discrepancy, as you can see in this slide. Next, please. However, these children also have eye disease, which is inflammatory again in 1/4 of them. This was, until effective treatment became available, the leading cause of acquired blindness in childhood. So it goes far beyond the joints in this case. It is asymptomatic and requires careful and periodic screening. Next slide, please. So this is JIA. JIA is not adult RA. Only 3% of the patient have the equivalent of adult RA, which has the rheumatoid factor positive. All the others are different diseases which are typical of children, may also occur in adults, and are of difficult interpretation. The next slide, please. So, diagnostically, no pain, usually, differently from adult. Swelling, loss of function, morning stiffness. The swelling sometimes is difficult to evaluate. Children are puffy. They're nice, puffy, and so swelling, as you see here in these ankles, is not trivial. They have morning stiffness. So the motto here, Loreto, back to the motto, is just simply observe them. Next slide. Don't ask. Next, please. But then there is ultrasonography because we are in the 21st century, and this is of great help. Next slide, please. So there are other challenging diagnoses, and these are particularly those for rare autoinflammatory disease and autoimmune disease, and Loreto alluded to them. So fever, skin rash, undefined musculoskeletal pain, sometimes loss of function in target organs. Here, some of the symptoms may be very specific and undefined. If one looks at these rashes, one would simply see an urticarial rash. This may be actually a sign of a rheumatic disease in a child. Next, please. So what are the 2 things here that we need is disease awareness, physician education, and primary physician education. Next slide, please. As well as reference networks and reference centers. And I think in Europe, we are lucky enough to have the ERNs, the RITA, and the the Reconnect that really tackles rare disease. The next slide, please. And let's talk about managing the disease. So it's actually great in children because it is acknowledged in the main, recommendation, recent and less recent, that clinical remission is the ultimate goal and is an achievable target, which means that we can have a lot of children with arthritis without arthritis or without diseases. Let me make you a couple of examples. Next slide, please. So this is, for example, in autoinflammatory diseases. Once you identify the target, the molecular target, the targeted therapies allows you to achieve complete response. No disease attacked in from half to 2/3 of the patients. But what is even more important is the response in the non-responders. So the one who did not achieve complete response actually have a marked resolutions of fever attacks, signs and symptoms of disease. They live without their sign and symptom. Next slide, please. But you can see the half empty or half full glass. We can achieve remission in the majority of our children, but still we have non-responders, we have refractory chronic diseases, we have diseases which are orphan from targeted therapy. So there is a lot to be done here to improve the management of the lives of our patients. Next slide, please. And I talk to something that is typical of pediatrician. You have to interact with the family. This is sometimes considered a challenge. Parents and grandparents are a challenge. They are not. They are rarely a challenge. They are really committed. There is an alliance to treat the children with them. And there are very rarely compliance issues with therapy because the parents and the grandparents are highly motivated. Next slide, please. But then adolescence occurs, which is a severe disease, untreatable, but that goes away by itself. And it has an impact in patients with chronic disease. It has an impact on the family. Now we have compliance issues, okay? And the multidisciplinary team is mandatory here, including a psychologist, often with group therapy. Next slide, please. And I'll finish with the motto, what to do with a child with arthritis without arthritis, living without sign and symptom of arthritis with no inflammation in the blood. Actually, 50 to 70% of the patient with JIA, for example, achieve this, and it's still disease even higher than 70%. So the point is how to manage a long-lasting remission, and I think that we need to do our homework here. 50% of the patient flare after tapering and withdrawing biologic DMARDs. That means that they are not cured, that they are maintaining remission. We need large studies for disease trajectory, and we need predictive biomarkers. And this is of paramount importance. It's a good problem to have, but it's a problem. The next slide, please. And eventually, I'd like to really open and set the stage for the next speaker. I think we have a real issue with losing patient in transition. This is taken from a very famous movie, obviously, translated a little bit. The age is critical, and we already alluded to that. We should not think that there is a predetermined cutoff age for transitioning. Every patient goes by himself or herself. You need to have perfect disease control to transition. We need to have adult rheumatologists with significant knowledge in the rare pediatric rheumatological diseases, and we have our homework to do here. We need a synergy during transition, and we love health professionals involved in the transition. Next slide, please. And here we come with the paper that needs revision. Loreto, apologies, you are the last name, but this paper needs revision in 2017 papers. There is a EULAR press recommendation and standards for transitional care of young people. Next slide, please. And I hate to do that, but I'll do it anyway. Next slide, please. Here are the statements, which you cannot read, I know, but you should read. Every one of us should read this. Either we are parents, physician, pediatrician, adult rheumatologist, We should read these statements because they are of key importance. And I'll close my presentation, next slide, please, with a few thoughts. So what is my wish list? We need significant more disease awareness in the pediatric world. We need education of primary care pediatricians and general practitioners around the world on these diseases. There's still difficult to treat patients and orphan disease without targeted therapy, and it's our business as scientists, physician scientists, to figure this out. We need predictive biomarkers to manage patients with arthritis, without arthritis, and we need to do proper transitions, which is also an issue. With this, I thank you very much, and I leave the floor.
Thank you so much, Fabrizio. So we've had already 2 rheumatologists, one from adults and one for children. And then we also have another type of community in the rheumatology or the treating rheumatic diseases who are what we call, let me see my t-shirt, it says other professionals in rheumatology. Who are the other professionals in rheumatology? So they are the nurses, the physiotherapists, the psychologists, and then we have the occupational therapist. We have an occupational therapist today with us. His name is Rafa Prieto, and he comes from the University of Granada. And he's doing a PhD in biomedicine. He has worked as an occupational therapist in projects in which he treated adults, very elder adults with hip osteoarthritis, but now he's totally passionate about a new model in what we call transition. So Fabrizio already talked a little bit about it, but it's taking all the recommendations that we have and how to actually bring them to real life. So we have here, Rafa, the floor is yours.
Thank you, Loreto, and thank you, Fabrizio, because you have made me easier for this presentation. So next slide, please. So I would like to start highlighting that some rheumatic and musculoskeletal diseases start during childhood, which is known as juvenile onset rheumatic and musculoskeletal diseases. And it is very important to know that half of these cases are going to continue during adulthood. However, the transition from pediatric to adult care face a number of complex challenges because it happened during the adolescence, which is a very difficult time because it has plenty of biopsychosocial changes in people. In this context, rheumatologists and health professionals in rheumatology find it very difficult to provide an appropriate, proper care for these people for 3 main reasons. The first one is the inadequate training they have. The second one is the lack of specific resources for transitional care. And the last one is the limited interdisciplinary collaboration between health professionals. So next, please. Previous studies have shown that there is a lack of resources or research or evidence-based knowledge in the field of transitional care, as it has been often overlooked during the establishment of appropriate guidelines. So there is no hard evidence-based knowledge. However, the few studies have been conducted have shown results that support that a multidisciplinary and coordinated transitional care plan can, on the one hand, improve the overall status of the patient and the readiness to be transferred to the adult setting, and on the other hand, is going to increase the continuity of the treatment, which is a big problem with these patients. Next, please. Now I want to show the patient perspective, not only the health personnel perspective, and for this we have to know that young people with juvenile onset rheumatic and musculoskeletal diseases have a unique developmental context, and it is very difficult from the diagnosis, both from child and from adult. Therefore, we have, during the transition from pediatric to adult care, we have to provide them with an appropriate support to address not only medical, but also environmental, developmental, psychosocial issues. So in this case, young people have to receive, they complain about the lack of knowledge and about the lack of support during this transition. Next, please. The transitional care is a critical need in rheumatology due to the huge impact that juvenile onset rheumatic and musculoskeletal diseases have. First of all, they are high prevalent. It is estimated that around 10% of children and adolescents suffer from this disease. Second, these diseases have a serious consequences for health, not only in the typical biological markers, but also in the school attendance, in work possibilities, and in the social participation. The third reason is that juvenile onset rheumatic and musculoskeletal diseases have a huge high socioeconomic cost, as they are estimated to support the 25% of the burden disease in Europe. The fourth reason is that only 15 or 20% of the patients who are receiving the transitional care programs are satisfied with this because they do not consider tailoring to their needs. And finally, as I have said before, we have to take in consideration the transitional care because the half of the diseases who are coming from the childhood are going to continue in the adulthood. Next, please. So in this context, I'm working in a EULAR task force which aims to improve the quality of transitional care, as Fabrizio have said before, is one of the topics we are working. And our first step has been to adapt the EULAR recommendation on patient education, patient management, and physical activity for the self-management of young people with juvenile onset rheumatic and musculoskeletal diseases during transitional care. Next, please. So how are we doing this? Our first step was to create a working group with pediatric and adult rheumatologists, with different health professionals in rheumatology, and with patient research partners from more than 10 European countries, and follow a Delphi method to make several meetings to discuss some points to implement in this sample. And we finished this process with 3 online rounds of anonymous online voting to establish the level of agreement. Next, please. In this process, we have obtained 4 overarching principles. The first one is that pain management, health education, and physical activity are mandatory topics to be provided for young people with these diseases during transitional care. The second one is that health professionals in rheumatology and rheumatologists have to consider the need of including digital health tools to improve the self-management of young people with these diseases. The third one is that the contents and the interventions provided during transitional care have to be tailored to the needs, preferences, and capability of the patients. And the last one is that transitional care success have to be measured both in objective and subjective measure. Next, please. The recommendation we get in this process are divided in 3 categories. The first one is that health education. We established that health education is an interactive process to support and enable the patient with juvenile onset rheumatic and musculoskeletal disease to self-manage their condition and to improve their overall health status. The second one is that the delivery format of health education has to be agreed with the patient in a shared decision-making process between the health professional or the rheumatologist and the patient. And the last one in health education is that health education has to be assessed in both terms, in terms of knowledge acquisition and in terms of establishment of healthy behaviors. Next, please. Regarding pain management, we have 2 different recommendations. The first one is, it is very important to highlight the relationship between a healthy body composition and pain on disability. And the second one is that non-pharmacological approaches are needed in newly diagnosed young people with juvenile onset and rheumatic musculoskeletal diseases, but this has to be combined with pharmacological approaches. Next, please. And regarding the last recommendation about physical activity is considered a part of a lifestyle, a healthy lifestyle, and it has to be promoted during all the life of the people. Physical activity has health benefits for young people with juvenile rheumatic and musculoskeletal diseases, and as it's happened with health education, physical activity has to be adapted to the preferences and the capabilities of each patient. Next, please. All this work I have shown here is what we are doing to create the EULAR mobile app, which is a digital health intervention to improve the quality of transitional care. Next, please. And with this slide, I will finish. I would like to show you which one is the intervention we are doing. We have 3 different steps. The first one is to collect data about pain, fatigue, and other biopsychosocial factors related to the patient during a month through an ecological momentary assessment. With all this data, what we are doing is to create an individualized network about how the pain, the fatigue, and the other biopsychosocial factors are related in each patient. This network is going to be used with the health professional and the rheumatologist to discuss between them and the patient which are the factors they consider more important to be treated. And the last step of our intervention is to treat the factors they have chosen during the shared decision-making process through the app with different contents. And thank you for your attention. I leave the floor.
Thank you, Rafa. So now we have heard some very interesting presentations from our rheumatologist and health professional. Now we are moving to something else. We are moving to a personal experience from a patient. And it's my pleasure to introduce Peter Boyd, who is Arthritis Ireland Services Officer and Chair of the EULAR Power Committee. Having been diagnosed with rheumatoid arthritis, osteoarthritis, and fibromyalgia, more than he has built his life to the point where he is no longer merely existing, but living a truly fulfilling life. And before I give the floor to Peter, I'll just encourage you to watch the video filmed by EULAR, and which is circulating on the social media. And it's a very inspiring video about Peter and his family and the ways he has been dealing with the rheumatic diseases. So please go on the social media and watch it. It is very inspiring. So Peter, the floor is yours.
Thank you very much, Susie. Thanks for that lovely introduction. And it doesn't give me any extra pressure whatsoever for what I'm about to present, to live up to that beautiful video that EULAR have produced. And I'm really proud to have been involved with that. I really want to focus on this, on the upbeat, the positive, the fulfilling life that can still be lived post-diagnosis. So I'm gonna look at it from this angle of all the things that I do and did when I started to really live my life after my diagnosis. I think everybody who's come across me or knows me understands that I had some very difficult times after my diagnosis. But as I began to rebuild my life, there were certain things that I was able to do, and these were the things that began to show my life as a living my life rather than just merely existing. And the first thing that I did was voluntary work and getting involved in voluntary work and being there. And these little stepping stones along the way to feeling better and living a more fulfilled life, they started with attending events, being a volunteer at them. There was talks. It was a juvenile arthritis event where parents were getting talks from specialists and consultants and important people. And I was there playing in the ball pit with the kids while their parents were getting their talks, and I was just interacting with them and having the fun and not really engaging in anything specific around arthritis, but just having that interaction and being involved, meeting other people with arthritis, meeting children, meeting their parents, talking to everyone about it. And as I began to do more and more events and I got more involved with Arthritis Ireland and the different services that we offer, I began to see that I was a reliable person. I began to see that I had some strength. I was able to offer something to people. I eventually came onto the board of Arthritis Ireland as a patient representative. And there I was able to use my voice to represent all those people living in Ireland with arthritis and all sorts of different RMDs. And I was able to be the one that they could come to, they could share their stories with, and I could represent them. So I was getting great strength from what they were telling me, and the fact that I had a bit of responsibility and I had a bit of character. And it went with self-management. At first, I was the patient. I took part in our self-management courses, but then I trained to be a leader and I delivered those self-management courses. And again, I was showing my reliability, my strength, and what I was able to do. And if we move on to the next slide, that takes us on to education. What I did before I was diagnosed wasn't compatible with my arthritis at the time. So I had to go back to education. And this is something that everybody can do if they choose to, or they can continue on in what they're doing. But I was able to focus on what I can do rather than what we can't. And when we're diagnosed with arthritis, or when we're told about this, there's so often we're told about what we can't do. And particularly at a younger age, you know, it might be in school, we're told not to take part in physical activity or in PE lessons. As we're getting older, we're told we can't do our work, we can't do this. But I really focused on what I could do. And as I got involved in education, I began to see my confidence grow. I got to see my self-worth really coming back to me, because that was stripped away when I was diagnosed. But as I got more confident, I was beginning to get praise again. I was beginning to get told that I was doing well. The lecturers in college were telling me, you know, Peter, you have a talent here. You're actually good at this. And I was beginning to see accomplishments coming out. So I was getting awards. I got Student of the Year. I got to see my results from exams and assignments were coming back, and I was getting good grades. And all the time through that, I was getting my confidence and my self-worth and my self-esteem was rebuilding. And I was beginning to see and come back to my longer term goals of living that fulfilled life, of living, not just existing. And all the time, I was getting support from people within the college to give me that extra time that I needed for exams, or they were giving me a computer to work with rather than having to write everything. They were sending me things up by email rather than reading it carrying books. All those little bits of support that I was entitled to, but I maybe wouldn't have had the confidence to ask for it initially. So it's all about building that confidence, building that self-esteem, building that self-worth. And again, you're building blocks that come along the way to take you from what was a very low position as you rebuild your life. And if you move on to the next slide, that also then feeds into the lifestyle and the relationships that you have as well. So I began organizing walking groups. We know how much exercise is important and movement. So I was meeting other people with arthritis, having our walking groups. We were also socializing then. So we were having a cup of coffee afterwards and a chat, talking about our families, how we were getting on. It completely changed what I viewed as socializing. What I was doing beforehand was going out after I worked in the pub and going out late into the morning and staying and not getting much sleep and drinking and all of those things that I'd done. But as I got older, I would have been changing that anyway. So I needed to change the way I viewed it. So now I was doing different things. Initially, when I was diagnosed, I gave up playing football. I gave up playing my golf, and I really focused on what I couldn't do. And I thought, oh, well, I have to stop all these things and I can't do these things that I enjoy and that I enjoy. But what I had to focus on was what I can do. So I can't play football to the level that I used to, but I can play five-a-side football. I can play it at a slower pace. I can do what I can. And if I don't feel well in a particular week, it's not as serious and as committed. So I can drop out for a week if I need to, if I'm having a flare. I can play golf. I'm a brutal golfer, but I really, really enjoy it. So I get to go out and play my golf now, and I don't worry about the outcomes of it. I have to plan it into my week or my month and make sure that I'm not doing anything else around it. But it's all part of the adaptations that we make so that we can live, not just have this diagnosis that is given to us and focuses and takes away from our life and tells us what we can't do. We need to be positive and see what we can. Even down to things like nutrition and the food that we eat and how we look after ourselves. Because as we've seen in the other presentations, whether it's weight or whether it's other things that come in, while they're not causes or they're going to take it away either, they all have an impact on how we live our life. So we need to have the strength within us to be able to move on. So if we go on to the next slide then, the importance of employment. It's something I always talk about. It's really about getting back to a place where you feel like you're living a fulfilled life. I really saw my career as a barman. I saw that was what I attached myself to. But when I had to retrain and I lost all the income and everything like that, as I got back into work, I saw that I was earning money again. I was getting that self-confidence and the self-worth that I got in college. So that's what we really had to do. I know that work isn't for everyone. Not everyone can get to the same position that I'm in, and I'm fortunate that I'm able to do my work and I'm able to work full time. But it's important that we try. And if you want to try, that you know that you can. Look to myself, look to other people for inspiration and see that you can do it. And like I say, if your identity is wrapped up in doing your work, that's not necessarily a bad thing. Keep going, keep trying, and you'll find a way to work it out. And if you have to go back and change, that's okay too. I never thought I'd flip from working in a bar to now being working in a kind of an administrative and an office type job. But I love it just as much as I love the bar work. So who knows what the future holds? You just have to roll with it and see what happens. And if we move on to the next slide, then I couldn't live a fulfilling life without medication and treatment. I'm not forgetting about it, but it's only one aspect. I didn't start this presentation with medication because it's only one aspect of my fulfilling life. All of the effective treatments I take allow my life to proceed, but they're not the biggest or the most important thing. All of the other things that I do to manage, to self-manage, to pace, to plan, all of those things combine with medication to get me to the point where I am now. But it's not just medication. And a very important point for me as a young man, don't neglect mental health in this. Make sure you're talking about it. Make sure you're asking about it if you're a health professional. Keep talking, keep men talking. We need to be asked about this. So if we move on to the second to last slide, we look at what my fulfilling life is. So what am I doing now? I'm a more mature person. I'm a more empathetic person. I can see the silver linings of my diagnosis, talking to all of you lovely people and traveling all around Europe and getting that exposure and the travel and everything else that goes with it. I feel like I'm making a difference now. I feel like I'm involved in something that's positive and really, really makes a difference. And I have my beautiful family that are around me. And anyone who has seen the video will know how important they are to me and why they matter. It's still tough. I'm not saying I don't have bad days. I'm not saying I don't wake up some mornings and just wish that I could roll over and stop and not and give into it. But when you can manage well and you take all of these things into consideration, that's when you can live your fulfilling life. So if we go on to the last slide here, this is what we're talking about. My fulfilled life with an RMD. My name is Peter Boyd. I'm a husband, I'm a father, I'm a charity worker, I'm a full footballer, I'm a golfer, I'm a friend, I'm a family man, I'm a manager, but at the very bottom, and it actually should be even smaller writing than that on the slide, I do have an RMD, but it comes very, very low down the list. And it's not as important as all those other things because I've chosen to manage it, to choose to make it not as important because I want to live a fulfilling life and not just exist. Thanks very much.
Wow. Remember, I told you, love. You have love in the chat a lot. Thank you for, focusing on what you can do and not on what you cannot do. That is very inspiring. So we have a few questions in the chat, and yep. You want to go through them, Susie, or you want me to go through them?
Yes, Loreto, I will. The first question is for Marguerite. How can patient organizations acknowledge, communicate about some of those risk factors, in particular the scary surrounding increased risk of mortality, in a way that it is helpful rather than making people more worried? And what helpful advice can be shared alongside that to reduce fear and worry?
Yes, I think this is a very important question that is brought up by Rebecca. I fully agree. I think education is here key. And education should be on all the fronts, of course. So patients' organizations can have a role there. This is also the education that have to be given by the physician, but also the healthcare professional, the GP. We all have to give the same message. I think that's crucial. And then, of course, it depends also a little bit which is the underlying rheumatic musculoskeletal disease, what we are talking about, how we should address it. So I shared with you some slides and some thoughts about osteoarthritis. I also discussed with you that you have their risk factors like obesity, for instance, and how important it is for your joints to have them be mobile. And when you, of course, are less physical active, then it's not only not good for your joints, but it's for your whole system, of course, that is unfavorable. So I think here is an example where it's important to make people that have this disease understand what are the mechanisms and educate them about a healthy lifestyle. But here it's also important on a population level, and that's maybe beyond patient organizations, but maybe is something that's important for whole society, is that we make people understand that joints goes about more than joints alone. It is about your whole system when you live an active life, when you are active and exercise every day, that it is important for your health.
Thank you, Marguerite. Before we move to the next question, which is for Fabrizio, may I ask you one question, Marguerite? Despite the fact that there are no drugs for osteoarthritis, do you think that early referral helps treating the disease and the patient? And also, if you can tell us if the supplements that are available and sometimes doctors prescribe, are they helpful?
Now, first is an early referral. I think I already mentioned that when you think about a cure, that we really can stop these bone enlargements to develop, for instance. That's not something we can do now. But when you think about, in fact, it's what also was my answer on the earlier question. Now we know that these lifestyle activities, as maintaining physical activity, maintaining a healthy weight, that is so important, and it is also very important how people develop in their complaints. That I think the earlier people understand that can encourage their self-management. So in that respect, yes, I think that is important to do. Then your question about the supplements, that's not such an easy question. There are a lot of different supplements. So you're saying supplements are good or not good, should be prescribed or not prescribed. I cannot say that because they are very different. One of the supplements, for instance, there is a lot to do about is, for instance, vitamin D. And I think, of course, it's important that people have sufficient vitamin D. That's good for your musculoskeletal system. That's good for your bones. So that's a supplement I think is important to get when you are short of vitamin D, only then. Then you have all kind of other supplements that you can sometimes even buy at the, not have to be prescribed, but you can buy themselves over the counter. A lot of these supplements now have a lot of evidence, and we now know more whether they are effective or not. And I would suggest when you want to use these kinds of supplements, really try to understand and ask your physician whether there is evidence or not and whether it's useful or not.
Thank you. Okay. Shall I do the next question, Loreto, and then give you the floor to do the rest? Yes. Okay. The question for Fabrizio. We too are very passionate about increasing awareness in primary care. We developed a whole campaign for it, and there's a link. But how to get these messages successfully to reach many primary care practitioners? Is there anything EULAR can do centrally to target primary care? Are there ideas for GPs? Primary care services can care about pediatric RMDs?
Well, thank you very much. I think JIA was and is a fantastic campaign. The issue with disease awareness with general pediatrician or GPs is that we have to try to find a way to reach them, and the way I see the campaign from Think JIA, Rebecca, is actually very focused to the general population rather than physicians. So I think it's, first of all, for us as EULAR members all together to make sure that we can organize satellite meetings, short conference within primary pediatrician meetings and GPs meeting or internal medicine meeting to make sure that we increase awareness for musculoskeletal diseases in children. Another suggestion that came to my mind, because I looked back to your material, and I thought that, unfortunately, it's only in English. And there are, at least, correct me if I'm wrong, but my feeling it is only in English. And although English is frequently spoken in several countries, may not be generally the language most used in the European Union. So I suggest, or I think that EULAR or Press and EULAR together, we can think about that, should actually, and it's a work for Loreto and Margaret as advocacy chairs, to think about translating this in several languages and making sure that we can reach as many European citizens as we can. There are now, artificial intelligence tools for translations. They're pretty good, actually. I was impressed. And I think we should think about doing this all together. I think the pediatric committee in EULAR would be very happy to engage into such an activity together with the advocacy committee. That would be my answer. It's a homework for all of us, actually.
Yeah, and in fact, it's very much related to a question that I had before I go to the chat, which is what are the major challenges? And one is that you're absolutely right. We produce a lot of very interesting things, and then how do we actually bring them to life? So how can we implement all these nice things we are doing in our task forces in EULAR, and then in the last minute, it's impossible to bring them to life. So all of you think about my question on what is the major challenge for rheumatic and musculoskeletal diseases, because that will be my last question. But now I want to go to a question that is here in the chat. It's a little bit long, but in summary, it's related to the delivery of medicines. Okay, so there are many ways of getting the medicines at home. Some ways to get it is to buy them on the internet, because maybe there is no access in your country. But there are this is Mike Guile from a patient safety and an association of patients, and so they talk. Whether any of you could comment on the level of importance in the treatment process about patient education on the delivery systems and on how to access the medicines, whether this is a problem or not. Any one of you want to comment on this? It's a difficult one. Huh?
It's a difficult question. Eh? Thank you.
Yeah.
We shouldn't thank you, actually. It's a very difficult question. Can I give a pediatric perspective? What we feel as pediatricians is that very often drugs are made available to children significantly later than to adults. And we have, despite the pediatric rule, which has been used very well by pediatric rheumatologists around the world, particularly in Europe and the US, to get drug as soon as possible, we still get many of the drugs significantly later. And this is unfair. I understand the safety issue of testing the drug before an adult, but I also would like a balance in between the safety and the delay in getting the drug to people, children and adolescents who badly need the drug. So this is one issue. I think we should work together with this. And the second issue is that there are discrepancies between countries in Europe, and this is not acceptable. So that people does what Mike writes. So they go on internet, try to buy the drug, it gets really complicated, and you never know. So I'm not sure we can do that, but I think EULAR has the political power and weight to make sure that European EMEA first and then the European Union address these disparities between ages and discrepancies between countries.
In fact, Fabrizio, this is one of the topics that we will discuss in a meeting with European Medicines Agency soon. So yes, this is very relevant.
Make sure that the pediatrician is there, please.
It is.
He will be.
Good. Good.
Yes. We have a pediatrician in the EMA liaison team. Yeah. Okay. Well, this is a question perhaps for Margaret, because you are representing the otorheumatologist. It's from Barton, who raised his hand before, but we have to do the questions through the chat. Gout patients are known to have a shortened lifespan. Is that the case for rheumatoid arthritis patients as well?
A shortened lifespan.
Yes.
Yes, yes, for rheumatoid arthritis patients, yes, I think so. And in the past already studies have been done in that respect. There was also a lot of research that tried to understand why that was. And the idea was that now we have much better medications than we had in the past, and the inflammation is much better suppressed, that maybe this extra mortality rate would have been gone. But unfortunately, in the more recent studies that have been done, we still see it's much better now, but we still see that mortality rates are a little bit higher in patients with rheumatoid arthritis than in the general population. And that's why we now as rheumatologists stress also very hard when we talk with our patients that it is so important, for instance, that when you have risk factors for cardiovascular diseases, that these are treated well. So that as in all patients, in all individuals, I think it's important that you be cautious, that you have a good blood pressure and that you have a good cholesterol in your blood, etc. But this is especially important for patients with inflammatory rheumatic diseases such as rheumatoid arthritis.
Yes, so it's inflammation that affects both in gout and in rheumatoid arthritis and in many others. Just to let you know that we have a brochure under advocacy materials in EULAR related to cardiovascular risks and also to other diseases that come with inflammation. So I think that was a relevant question. In fact, we also had a comment from Meti about mental health. It's misused in talk between patient and doctors? This is not it's not a question, but it's a comment. What do you think about about mental health and how we are treating it in rheumatology?
Shall I comment on that, Loreto? Yes.
Go ahead, please.
Yes. Now, I think it's an important remark. As I mentioned in my talk, I think we now know from studies that have been done that patients that have rheumatic musculoskeletal diseases have higher rate of depression and anxiety. And I don't know whether that's always that well addressed, and we are all aware of that. I think when you are with your rheumatologist, that often there is a lot of attention for what's going on in your joints, but there is much more, of course, the impact is much wider than only what's going on in your joint or directly on other organ systems. That can also be the case also that are directly related to your rheumatic disease. So I think it's important that we realize all these other important aspects, whether it be comorbidities we just talked about, the work aspect. I think that was in the presentation by Peter Boyd, an impressive topic, that work-related health problem and how you can enjoy work, how important that is also something we should address. But the mental health issue is as well.
Yes. I don't know what, I mean, Peter mentioned it, and I don't know, Rafa, you also mentioned it, aspects of mental health in the app that you are developing. How is that integrated? How is mental health or included in the app?
So what we are doing now is to create some content, but we would like to start even before they use the app, because when they are talking with the rheumatology, the pediatric or the adults in transitional care, we consider that it's a critical point for mental health. They have a higher rate of anxiety and depression. So we have to let them know that it's normal to feel in that way. They have to, as Peter told before, it's not about good or bad days. They are going to be all of them in during the life. So they have to know that they are going to have hard days, they are going to have good days, they are going to be during a period in not the best mood. So I think that there is a problem with the communication with the mental health in this concrete sample in the adolescents is more difficult. And I think that the main point is to let them know that it's normal to feel in that way. They have to understand it's a process and they have to work with that. We have to deal with these symptoms.
Mm. Yeah, in fact, there in the video, you all have to watch it, from the story of Peter Boyd. He mentions two words, communication and honesty. And sometimes honesty is more to you and to the ones around. And that's the first step to heal your soul, right? So in fact, this takes me to the next question. This is for Fabricio from Theodora. What is your suggestion and best way for a smooth transition from children to adult?
The best, it's impossible to have the best suggestion on transition. Rafa knows even more than I do, because he's overlooking the process. I am looking at the process of transition from one side. And so it's difficult to understand what is the best. I think that if I were to, provide a piece of advice, would be get prepared to it. So start preparing it as soon as you think you might get there, and there is not just a cutoff age. Just think about your single individual patient and try to think about it and discuss the issue with the young adult or young person, YP, it's called in the recommendations,
Mm-hmm.
in the young person, with the young person and the parents, but then progressively only with the young person. They have to become protagonists of their own transition. More, Rafa, if you want to add anything, you oversee the entire thing. I just look from one perspective.
No, I totally agree with you. I think that the main point is that we have to forget about the cutoff. It's not the same for every person. So if you have, 9 years, but if you are 12 years, it's not the same for you. The point is that we prepare all of them for the process. We provide all the content we can, all the resources, all the strategies, but they are going to use in a different way. So there is no a standard way. There is not the best way. It's each one way. I think that is the point. It's very individualized.
Yes. Do you want to ask something, Susie, or shall I go with my last question?
Yes. I have a question for Peter. So I was wondering, Peter, what was the turning point, that trigger point that after diagnosis that made you change your perception of life and take life into your hands and start living again? What was that made you do that?
Thanks. Yeah, I suppose what for me was meeting other people who were in the same position as me and realizing that there were people who were better than me, who were impacted more than me, and getting a perspective on how my life was changing. And that was so talking about it, meeting others who were the same as me, and that comes back to awareness. So that's what we all need to do, is to raise awareness and raise the understanding. of the general public about what's going on.
Yeah, again, communication. Yeah, if you see others, and yeah. Fabrizio, do you want to ask something? We can.
Yes, yeah, and actually, it's not a question to Peter, it's a request. I love, Peter, your motto, focus on what you can do and not on what you cannot do. I think we have to find a way to get this into a real motto, because I think this is key in what you were alluding to, changing your perspective, changing the perspective again to life. So if you were so kind to send me the motto and we can work on it, I really liked it.
That's no problem. I haven't trademarked it. I haven't got the rights to it. So I wish I did. I could sell it to you, but no, it's free to use.
Well, you know what? I'm seeing here a very clear motto for next year World Arthritis Day. Focus on what you can do. Yeah. Okay, so then my last question will be to each one of you, what is the major challenge from your perspective for RMDs? Don't go too long, just try to identify one major challenge. Who wants to start? Margaret?
Yeah. For me, the major challenge is that most of these diseases are chronic and not curable. So I really hope still in my working age time to see that more of these diseases really have a cure.
Yeah. Fabrizio?
Can I go for two?
Okay.
What is we need, echoing what Margaret just said, we need more research. We need more understanding of disease mechanisms and identification of novel therapeutic targets. So this is something that I think is a major need for rheumatic skeletal disease across all ages. And the second one, it's for us pediatrician, is disease awareness with the GPs and the general family pediatrician. That's an easy one.
Yeah, awareness today is the awareness day. So yes. Peter? Oh, Rafa, you open your mic.
Okay, so I think that maybe it's for my background, but I think that we should stop finding like only an ideal way of working, and we have to work in a tailored way, in an individualized way with people. At least in transitional care is the main challenge, how to do this, but we are looking for.
Yes. And Peter, because you do wonderful closing, so tell me, what is your challenge?
Can I have two too?
Yes.
Yeah. Well, then I definitely want improved access to care. So that goes on with individualized care as well, and definitely primary care awareness, so that people are referred to rheumatologists quicker, they're seen sooner, they're getting onto their treatment sooner, and just more knowledge of that in that area, from children right the way up to the oldest people in our community, because we are all going to live longer, and there's going to be so much more. So we need to have that awareness in primary care that we can be referred to where we need to be quicker, and we can get treated quicker.
Yes, awareness, which is very much related to education, which is much related to quality of care research and so forth. Yes. So thank you all very much. Susie, I will let you close this webinar. It was a pleasure to have you here.
Yes, thank you, Loreto. First of all, it was a pleasure to share this webinar with you. Thank you very much. And I think we've had some very interesting presentations, and out of them, we have some really strong slogans that we need to raise awareness also on national level by our organizations, and keep informed early diagnosis for preventing rheumatic diseases, deformities, and other problems. And yes, the motto of PEDER, we focus on what we can do, and not on what we can't do. It's very important because even if we are patients living with a rheumatic disease, a chronic disease, there are a lot of things that we can do, and we need to adapt our lives and continue to have a good quality of life. Thank you all for your attendance, and wish you a very nice rest of the afternoon.
Bye-bye. Bye-bye all. Thank you all.
Thank you.
Bye-bye.